Remember back when we first talked about granulomatous inflammation, and then we said that we'd talk about it more later? Well, now it's time to discuss it. So, what is a granuloma and how does it form? Well, we're going to do this by saying that we actually break them down into two main types, non-caseating and caseating granulomas. Now, do you remember what the word caseating actually means? It means cheesy. What does cheese have to do with anything? A lot, actually, because certain pathogens like tuberculosis have very thick, fatty cell walls, and when they're broken down, they cause the tissue, whatever tissue surrounds them, to look cheesy. And if a granuloma is formed, it will be a cheesy or caseating granuloma. So now that we got that cleared up, let's talk about how granulomas actually form. First of all, what cell do you think phagocytose and process this TB? Macrophage, right? The big eaters. And it will stick a chunk of it on its surface. On what receptor do you think? MHC2 receptor. Very good. What cell will complex with this receptor? T cell, right? And more specifically, a CD4 T cell. Now, for immune cell stimulation, we always need two main signals, right? The first one will be involving receptors. So there's a receptor on the macrophage. What's that? B7. This will complex with what receptor on the T cell? CD28. Very good. And the second major signal involves cytokines. So what cytokine will be released from the macrophage? TNF alpha will go and stimulate the T cell. What about the release from the T cell? What cytokine? Interferon gamma will in turn stimulate the macrophage. So this is called co-stimulation. So now both of these cells are stimulated fully to the max. And what will this do? What's the point of that? So this will cause the macrophage to activate its lysosomes and be able to degrade this TB organism. Not fully, by the way, as we just discussed. It'll be emulsified, leaked into tissue, and cause it to look caseating. But it will be degraded at least, so that's good. It also will cause some of the macrophages to actually join together and combine nuclei, and we see these so-called multinucleated giant cells in tissue, and that's like a trademark of granulomas. So when you see those, you can think granulomatous. Alright, what does a granuloma actually look like? Well, here's a nice little picture. It's like an inner circle of macrophages surrounded by a periphery of T cells. So on the inside, macrophages are trying to wall off and degrade this TB organism, and the T cells on the outside are stimulating them and encouraging them to keep doing what they're doing. So that's a granuloma. Pretty simple and clear, right? Good. So let's test some of your knowledge with a flash quiz. Whoa. What are some examples of granulomatous diseases? What do you think? Let's start off with caseating. Well, we just discussed them. So tuberculosis and some other types of fungi, like histoplasmosis, coccidiomycosis, and some others as well, maybe blastomycosis. What about some non-caseating types of granulomas? What do you think can cause those? Well, autoimmune diseases actually. Like, can you think of some examples? Crohn's disease and sarcoidosis are probably some of the best examples. And then finally, certain substances can actually trigger granuloma formation, like silica that we see here and beryllium. So people that inhale silica, who work in a foundry or who mine, can actually end up with granulomatous inflammation in their lungs. Okay, so now it's time to talk about fluid, and more specifically fluid in the blood vessels, or the capillaries, and fluid on the outside of the blood vessels, which is called the interstitium. How do we know where fluid is going to end up? Is it going to end up in the interstitium or the blood vessels? Well, to answer that, there are two main forces that determine where fluid is. Do you know those? Well, the first one we'll talk about is hydrostatic pressure. So basically, just remember that things like water and anything, things diffuse from high concentration to low concentration, right? So wherever there's a greater amount of something, it will always flow to an area where there's a lesser amount so that everything is equaled out. So that's what force we're talking about here. When there's water, more water in the blood vessel than there is in the interstitium, the water will have a tendency to want to flow down its gradient, and that is called hydrostatic pressure of the capillary. There's also hydrostatic pressure of the interstitium. Okay, so that's the first main force. The next one is oncotic pressure. It's spelled like this, oncotic pressure. And there are two forces in general. So there's an oncotic pressure that pulls fluid out of the capillary, and likewise there are solutes that drive fluid into the capillary, into the blood vessels. In general, proteins and sodium are the main factors that are responsible for the oncotic pressure. And proteins specifically, when we're talking about within the blood vessels, do you know what protein is responsible for the oncotic pressure? Albumin. And albumin is synthesized in where are most proteins synthesized? The liver. So that's why if we have problems with our liver, then we can have problems with albumin synthesis and then problems with fluid shifting. So we'll talk about that in a little bit. But this equation sums up all the forces. It represents the net driving force, the net direction where fluid will flow. So we determine this by finding the difference between the hydrostatic and the oncotic pressures of the capillary and the interstitial fluid. So that's how we find out the sum force in what overall or net direction fluid will flow. So let's talk about some examples now. Typically, fluid is in your blood vessels, right? Right. But sometimes it can leave, actually, and that is called a transidate. So transidates are collections of fluid that is primarily hypocellular, watery in nature. How can those arise? Well, one common way is affecting either the hydrostatic pressure or the oncotic pressure, what we just talked about. So what can affect the hydrostatic pressure first? Well, let's say that there is a clot, and then there's a backup then of fluid behind that clot. So that's going to dramatically increase the concentration of water molecules, which will then increase what type of pressure? The hydrostatic pressure in the capillary, and that will cause fluid to actually leak out. So that's one way a transidate can arise. Another way, so we see water leaking out there because of the increase in hydrostatic pressure within the capillary. Another way then is affecting the oncotic pressure too. So how can we end up with a transidate affecting oncotic pressure? When we're talking about oncotic pressure, normally we have solutes like proteins and sodium that are driving the fluid into the capillaries through this oncotic pressure. And when we're talking about proteins, what type of protein again did we say was primarily responsible for driving the fluid into the capillaries? That was albumin, right? And where was that synthesized? The liver. And we briefly mentioned that if we have liver problems like cirrhosis, where your liver just scars over and you have a complete shutdown of your liver, then you will have a decrease in protein. And a decrease in protein, specifically albumin, will decrease this oncotic pressure and provide less of a pull, less of a driving force for fluid to stay within the capillaries, within the blood vessels, and it can leak out. So we can also see this in hyponatremia, when we have a decrease in sodium too, low sodium states. Anything that will decrease this oncotic pressure will lead to a transidate of fluid. So now that we've talked about transidates, let's now talk about the more cellular, purulent, high protein content fluid called exudates. So exudates arise not from those forces we just talked about, but generally from whatever triggers inflammation that we discussed in previous slides. So like a knife wound or trauma or infection or anything that will disrupt the integrity of the endothelium will lead to exudates, because now there's a gap here where whole cells can actually flow out of and into the interstitium. That's called an exudate. There are actually several criteria that determine and help you figure out if a collection of fluid is either an exudate or a transudate. Do you know what those criteria are? Leitz criteria. And this is commonly tested on boards, so it's important that you know the 3 Leitz criteria. If any of them are true, then it's an exudate. So what you do is you actually compare the fluid collection that's in the interstitium to the fluid in your capillary. And you set up ratios. So the first one is a protein ratio greater than 0.5, comparing the protein that's in the interstitium to the protein that is in the capillary. If that's greater than 0.5, you have an exudate, because there's a lot of protein in here, more consistent with an exudate. The second is LDH, which is another protein, an enzyme. And if that's greater than 0.6, then you have an exudate. And the final one is LDH, the raw number. If it's greater than 200, then that is an exudate by definition. So I hope all that stuff is clear. You can go back over this yourself, but it's a very important concept that you need to know and will help you figure out a lot of different diseases associated with transudates and exudates. Okay, so now we're going to talk about one way we measure inflammation, and it's using the erythrocyte sedimentation rate, or ESR. Whoa, a lot of words, that's a mouthful, but basically it's a fancy way of just saying how much inflammation is taking place. If there's a higher ESR, there's more inflammation. And essentially what this test is just seeing how fast red blood cells fall in a beaker filled with some fluid. So let's compare red blood cells from a person who has normal blood, no inflammation taking place, and someone who has a lot of inflammation and a high ESR. So who would have a lot of inflammation chronically over a long period of time? How about someone with any diseases you can think of? Rheumatoid arthritis, or cancer, or lupus. Right, very good. So basically, what will differentiate the speed of which these red blood cells fall to the bottom of the beaker will be the amount of inflammation and inflammatory proteins. So someone with chronic inflammation will have, antibodies and fibrinogen and other acute phase reactants in their serum. And this will actually cause the red blood cells to all bind to each other in complex so that they're more dense. So that the speed of which red blood cells fall will be normal, a normal speed in a normal individual. And in this person with an increased inflammation, would you expect them to fall faster or slower? Well, because they're more dense, they will fall at a faster rate. And that is associated with an increased ESR, and that is how you can test for just generalized inflammation over a long period of time in an individual. Okay, so now it's time for another random topic, and that is iron poisoning. So sometimes children mistake iron pills actually for candy because they look similar, look nice and shiny and juicy, and they ingest iron, which is not very good. Why do you think that's not very good? Well, recall a reaction that generates free radicals using iron. What is that reaction? The Fenton reaction, right? Right. And what happened? What occurred with that reaction? Well, it took hydrogen peroxide and reduced it into a hydroxyl free radical, which just wreaks havoc on the insides of whoever ingests the iron. Not very good. What type of havoc? Well, I'm going to ask you. What are the acute and chronic effects of iron poisoning? So acutely, all that inflammation and free radical damage will lead to just massive bleeding and potential hemorrhage. All right, what about the chronic effects? Well, just like with any type of inflammation, the long-term effects of severe inflammation leads to scarring and adhesions, which can disrupt the motility of the intestines and interfere with how a person digests and may lead to extreme long-term pain.